again, my name is Calen Steiner. I'm a senior fellow here, and I have an interest clinically in IBD, and I also have a laboratory-based research program studying inflammation and fibrosis. And I'm really honored to be talking with Sandra here to you guys about shared decision making.
Yeah, hi everyone, it's Sandra again. And for those of you who weren't here earlier, I live with Crohn's disease. I've been living with Crohn's disease for about 27 years. And I also do a little bit of work in called patient-oriented research in Canada, but basically really kind of bringing the collective patient voice to health research. I'm super excited to be co-presenting this topic with Dr. Steiner today. This is a area I'm quite passionate about and really believe is sort of the pinnacle of person-centered care. And I do think shared decision-making helps to establish trust and therapeutic clinical relationships. Okay, so we're gonna start off with a poll. And the question is, what would be your preferred approach to IBD treatment decision-making? I think Dr. Higgins will launch the poll here in a second. There we go. So the options being, I decide on my own. I decide on my own after hearing from my healthcare provider. It's a shared decision between myself and my healthcare provider, or my healthcare provider decides for me. We'll just give you about 20 seconds.
And we do have over 60% have voted already. You guys are faster. I think you've gotten the speed up. So actually, I think it's pretty much filled out pretty quickly. So I'm going to go ahead and close the poll and show the results.
Great, thank you. Okay, so what have we got here? Oh wow! So we have 13% of people who responded that they would like to make the decision after hearing from their healthcare provider. 84% would prefer the shared decision-making option, so that the healthcare provider and the patient are working together to make a decision. And 3% would prefer for the healthcare provider to decide for them. So this is a good, this will frame, so we're gonna set the stage a little bit, give you a little bit of definitions and what does evidence-based medicine and shared decision-making mean, and then Dr. Steiner and I will have a little bit of a discussion. So I'm gonna pass the baton over to Dr. Steiner.
All right, thank you. So yeah, so first we'll talk about, just really briefly about evidence-based medicine. And I think that the reason it's important to talk about this for this talk on the shared decision-making is because evidence-based medicine is kind of a framework for making clinical decisions that we use on the clinical side. I was kind of surprised when I looked into it a little more to realize this was actually came about 1981 was the first time it was mentioned, so it's newer than you might think. And it's not that physicians didn't use science or clinical trials to make decisions in the past, but around that time is when physicians really started saying, we need to have a framework for how to evaluate the evidence that we have and to logically and reliably apply it to our patients to make decisions. So at its core, evidence-based medicine is a method to seek reliable answers to help find the right treatment for our patients. And it is based on proof, not just theories or expert opinions. And with this kind of movement, there was really kind of an increase in stringency in how studies are performed, protocols for how studies are performed, protocols for how data is analyzed. Prior to this kind of evidence-based medicine push, there was a lot more variability in how these things were done. And this approach also includes informing our patients so that they can really understand the pros and cons of the medical options and participate in that decision. So, and then the next, we'll go to the next slide. I'll talk a little bit about shared decision making. And so this is an approach where clinicians and patients share the best available evidence to make those difficult decisions. And the goal is to support patients to consider their options and to inform them, to help inform them to make really informed choices and informed preferences about their treatment and their care. And so to really engage in shared decision making, you first have to acknowledge that a decision needs to be made, know and understand the best available evidence, and then incorporate not just the evidence, but also the values and preferences of the patients. And so I guess, in short, it can really be summed up as a conversation between you and your doctor, and whereby it's a knowledge sharing and then a decision sharing. So ideally, the doctor would share their evidence and their thought process with you, and you, the patient, the person, would share, your needs and your goals, and then those would become integrated into a shared decision.
Okay, so I'm going to talk about a global initiative that this started about 4 years ago, which really was meant to encourage healthcare providers to ask their patients, what matters to you? And this simple yet profound concept can help to create deeper personal engagement with patients and their families, and a deeper understanding of patient preferences, needs, and values when making treatment decisions. This What Matters to You initiative originated from Dr. Michael Berry and Susan Eggman-Levitin, and I hope I pronounced her name right. They introduced the concept of what matters to you in the context of implementing shared decision making. And so it really kind of flips from, when you, as a patient, we sometimes will enter the doctor's office, and I know for myself, I sometimes feel like we just get right down to business. So what's the matter with you? And we really focus on the physical manifestations, say, of inflammatory bowel disease, and we really try to get to, okay, so what are we going to do about that? And then shifting to the question, so it's still important to ask that question, what's the matter? But then shifting also and asking the question, what matters to you? And we're going to talk about goal setting in just a little bit. And so that's really can help frame. So if as patients we have short-term and then perhaps long-term goals in our life for our disease, and the different things that we have plans for, this helps to figure out our motivations and what kind of treatments we might choose, our motivations to taking treatment. So I don't know, it could even be a short-term. I remember, as a little story really quickly, I remember I had my bowels were starting to stricture, and I was really struggling, and my husband and I had a trip planned to go to Rome, and I basically said to my GI, we just need to do something for this next little period of time so I can get to Rome and eat some pizza and enjoy this trip. And then when I get back, we can, deal with the rest, which was likely surgery. And it did end up being surgery, but I just needed to get through that short period of time so I could go enjoy that trip and then come back and deal with what I needed to deal with. And then, and then of course we have our long-term goals as well. So this can really personalize those treatment decisions or our healthcare decisions that we're faced with on a regular basis. And so then we're going to go into, I think this one's me, right, Calen? Yeah. So we're going to talk about some of the major decisions that we're faced. And Dr. Steiner and I are going to just provide some examples of how, so from a patient perspective, how I might approach a clinical encounter. And then from Dr. Steiner's perspective, how he prepares for a clinical encounter, because we're really both in very different lanes when we live with the disease, and then the gastroenterologists who have very technical knowledge of the disease and how they approach those appointments. So some of the things are medications that we might be starting. We have to go through many tests to monitor our disease, monitor how medications are working, etc., whether or not we might be facing a medication change or escalating the dosage of our medication or de-escalating. And so just as some tips from my own personal experience, for me, I really like information and tend to ask a lot of questions. It might annoy my GI. I also tend to be a bit of a negotiator in my appointments. So I usually prep some notes in advance before I go into an appointment. I do my research. I look into options. So depending, if I'm going in to discuss treatment options, for example, I'll sort of figure out what are my options that will be available to me. And then in the context of my life and goals, what would be that best option? So just as a quick little example, I live in a rural area, and I don't have as easy of access to infusion clinics. And I think I explained earlier in the last presentation that I also don't have great veins. And so for me, being independent is really an important thing. I prefer to have the self-injection. So that kind of would bubble up to the top of my list because of certain aspects in my life that would make that more convenient. And so then I would enter in and just have those discussions with my GI based on some of those ideas that I've already thought about. Dr. Steiner, do you want to pipe in on this one?
Yeah, sure. So, obviously the preparation from our side is slightly different because, as Sandra had mentioned, we're in a little different lanes. So when I'm preparing for a patient encounter, I usually start with just a review of everything I know about that patient. And so sometimes it's a brand new patient and I have to look at some outside records. Sometimes it's a patient that I know very well. I've been in my clinic for a long time, but I will go back and review kind of the vital things. What is their diagnosis? When was it diagnosed? What meds are they on? What meds have they been on? What extra intestinal manifestations they may have, what complications, if they've ever had a surgery. So I look through all of those notes, and then I look through all the procedure notes, so all the endoscopies we've done. Next, I'll look at the imaging, so CT scans, MRI scans. I always have to pay special attention to whatever the most recent endoscopy and the most recent scan has been. And then I look over the labs. I see when we last checked labs, what their inflammatory levels were doing at that time, if they had any. And then kind of the final piece before the visit starts is I look at all the most recent notes. I look for any phone notes. And sometimes I just remember having talked to them on the phone to try to get a sense of what their current situation is. So have they called into the clinic recently, talked about inflammatory symptoms that I know that, okay, today we need to really be talking about either something I did over the phone, has that change helped, or talk about making a medication change. Sometimes it's someone that has been very well controlled that I have not seen them for 6 months or heard from them. And then, I'm hoping that when I talk to them, it's nothing but good news. And then, the last piece of kind of preparing to make decisions is, when I walk in and start talking to them, I think I usually try and start off with trying to get a sense for all the things that Sandra just talked about that she prepares for, which is collecting that knowledge from the patient right at the beginning of the appointment. So that's kind of how I approach preparation for the appointment.
Great, thanks. Okay.
Yeah, and so I think with this slide, we were just wanting to kind of emphasize that the shared decision making is an active area of research. And on the right side of this panel, we have a publication. So it is being published in peer-reviewed scientific journals. It has been shown to lead to better outcomes. People are actively studying and making new tools to help with shared decision making. And I know Sandra is one of the people who is studying this and involved in these projects. So it is a very active area of research for the medical community.
Okay, and you know what? I just realized I don't think our cameras are showing, are they? I wonder if I kind of escape out and.
Your cameras are showing.
Oh, are they? Okay. Oops. Okay. Well, let's just fast forward really quickly. So Dr. Steiner and I thought we would ask each other just a few questions again, just to sort of show that we really are in different lanes and think of things maybe a little bit differently, and when we're approaching these clinical encounters, and sort of that idea that we're really bridging the gap and sharing information with one another, and then coming to a mutual agreement in an appointment. So I'll ask the first question to Dr. Steiner. What's the biggest challenge that you face when discussing treatment options with your patients?
Yeah, so I think the quickest answer that comes into my head is something that people have alluded to previously, which is insurance and payment piece. And that's one of the most challenging things when discussing treatment options with patients, because that's something I unfortunately have very little control over, and it is extremely complicated. And so that is a huge hurdle with any, even if we can come to an excellent shared decision that we both feel very good about, that's only part of the part of the journey. So that's probably the most challenging thing, but really just integrating all of the needs of the patient into the decision is something that is also can be difficult, but we always strive for. And then, so I guess, and then I would ask you the same question. What would be, from your perspective, what's kind of the most challenging thing?
Yeah, so that's changed a lot for me over the years. I think I do believe as, you live with a chronic disease over time, you mature as a patient as well, just from learning and figuring things out, sometimes the hard way. So I think now for me, because I've cycled through a few biologics, it's kind of keeping that hope that new medications are in the pipeline, and that if, hopefully, knock on wood, that, the medication I'm taking right now continues to work for me. But if not, that sort of, oh gosh, is this next thing going to work? What's that going to be like? I think I used to have more questions around the risks involved and perhaps even side effects. I've been very lucky to have very little side effects with medications. So I think overall, currently where I am with my disease, if I'm entering into appointment, I really want to know the logistical pieces. So, how is this going to kind of affect my, sort of fit into my life? So that's why I keep going back to that self-injection. I really like the independence of being able to do that. It takes very little time, the comfort of my own home. And I think, and supports, I think the supports of having education and information and sharing that, the evidence-based information between the doctor and the patient. So, but yeah, I guess in short, the biggest challenge for me is always kind of maintaining that hope that something will be out there. If I was able to give a tip to the patients and perhaps newer patients, I feel like it's just such a better time right now for newer diagnosed IBD patients coming into this space where there's lots of options and there's different ways of approaching those options that can hopefully sustain longer term remission for people and better outcomes. Do you want me to ask the next question, Dr. Steiner, or do you have that, Andy?
Oh, sure. No, I can. So yeah, so the next question I think we both wanted to talk about was a situation where the medication that the gastroenterologist recommended was not the medication that the patient wanted to take or had an objection to that, and how we each approach that from each side. So I guess I'll start by saying that from my perspective, that is not an uncommon occurrence where a medication that I want to start is maybe something that patient is hesitant to take. And I think, how do I address it? Well, the first thing that I try to do is understand why they feel that way, and I think that's the most important thing to start with. So I just ask for clarification and just really the reasons why. If I'm making a recommendation for, say, Remicade, and they say, well, the patient says I don't want to take Remicade, find out why. I will say very frequently the patient has very good reasons for not wanting to be on Remicade, and maybe it's something I hadn't thought about yet. And so oftentimes I will agree with the patient and say, oh, actually, I agree. Let's talk about something different. In the event that I still feel, I still just really feel Remicade is going to be the best for this patient, even though they may raise valid concerns. In that situation, I think I almost always have a couple other things that I think would be medically appropriate that we can try, but I just try and communicate what the other options might be and maintain clarity. If my primary recommendation is A, I will say, this is my primary recommendation, but I think B and C are also potentially appropriate medications. So let's talk about those and see if they'd be interested in pursuing those. And so I think the most important thing when these kind of situations arise is just the two-way communication. So how about you? What about when your doctor wants to prescribe a med that you're not necessarily convinced of?
Yeah, well, I'll use my more recent. It was a little while ago now, but experience, and it wasn't with the biologics. I'm kind of on board. I know the benefits. I'm probably the best patient now. I never miss a dose in regards to that. I just know how amazing it's worked for me. But my last surgery, which now just sounds like an oxymoron, like what you had surgery, but why you said biologics work well. So I was on Remicade, it stopped working, went to Humira, it didn't work as well, and I ended up in surgery. Now I'm on Stelara, it's working really well. So my last surgery, removing more bowels, so that was my 4th surgery. I had very high output. My transit time was half an hour. So from the time I ate something to it coming out was half an hour. I was literally an input-output machine, just trying to keep up with eating and going to the washroom. And so my GI had recommended that I take liquid codeine, and I really did not like the idea, mainly because it just seemed like pure narcotics that I was going to be putting into my system, and I was very worried about becoming dependent on that or addicted to it. And so I sort of resisted and tried to manage it by diet, and it was not working. And I think basically I just had to get to a point where I was really ready to accept that having to use that as a tool. And it was actually over. So it took about 1.5 years for my bowels to kind of readjust and settle, because I was completely obstructed when I went in for surgery. And so once the surgery happened, my bowels were wide open, and I think my bowels were used to working really hard. And so it just took some time for them to kind of calm down and get used to the idea that they don't have to work so hard to push through a little pinhole. And so, yeah, I did end up using the liquid codeine to slow my bowels down, which again helped to improve my quality of life, because I wasn't living near the washroom and eating nonstop. I felt like I was just wasting money putting food in my mouth, and it was just coming straight out. So you know, it's just sometimes really the fears that come up when thinking about, I guess, taking certain medications that can be really hard to get our head around. So I would say that was my most recent struggle of accepting that I needed to use that type of medication to control a problem that I was having. But in the end, it definitely helped. And now I don't have to take it. I've been able to kind of back off and, you know, move to Lomatil. So that's been good as well. And how are we doing for time? I'm wondering if we need to move to Q&A, or do we have time for one more question?
I think one more.
Okay. So Dr. Steiner, I think you had put this question together, so this one might be a little better for me actually, and maybe we can kind of flip it to you and how you. So you had put a question together that's how have your treatment goals changed since you were diagnosed, and how do you anticipate they may change in the future? So I think we touched a little bit on that. I was diagnosed pre-biologics for one, and like Ben said earlier, nothing really worked for me, and I found that very frustrating. I was really ill for like 7-8 years, living with a lot of pain and having to be around the washrooms, and so I didn't really have those goals because I felt like nothing worked. I didn't see that light at the end of the tunnel. I didn't see how things would work because I hadn't had that experience yet. Now, knowing what I know, and having the experience of having success with different biologics, if I were able to sort of back up the clock, and you know, if I was diagnosed at this time, I would have very different approach in how I, you know, sort of started on the medication path. I would start right away. For one, I had very severe active Crohn's disease pretty much from the get-go, and so knowing my history and kind of how that played out, I would start right away on the biologics and try to get that under control a lot sooner than waiting for 8 years until my, you know, bowels were so diseased I needed to go in for emergency surgery. and then just to really try to keep on that track. So if I lost, if the biologic stopped working, then I would immediately move to the next one and just really try to maintain that stability so that I wasn't damaging my bowels over a long period of time. So yeah, it's changed a lot. Now I'm kind of in that, like I said earlier, in that stage of just hoping that research and new medications are in the pipeline, so that if hopefully, like I said, knock on wood, Stelara continues working, but if I am faced with that I do have some other options. Yeah. And how would you have conversations with your patients?
Yeah, so treatment goals obviously can change, and for both clinicians and the patient. And I think, as you said, if you come into the office and you just were diagnosed and you have really severe inflammation, I think it's kind of an urgent need just to control inflammation quickly. But then more longer term, we often do that with medications like prednisone. And long term, the goal is we don't want someone on prednisone for prolonged periods of time. And so the goals, even within an individual patient's medication choices, change. Also, the way we treat IBD is constantly changing, and we're constantly finding better, newer endpoints. So I think, in the past, we used to base a lot of our treatment decisions just off of symptoms, and we now appreciate the importance of actual mucosal healing on endoscopy. So then that changes surveillance recommendations, because to see what the mucosa is doing, we have to do an endoscopy to do that. And so, and then there's a lot of data out there. There are different modalities for monitoring treatment response, and there's not really a uniform way to do that yet. But I guess my point is just that as we learn more and more about the disease, the short and long-term goals change for us also. And I think what used to be good enough in the past, no one is accepting as good enough. When we're starting to see some of the long-term effects of incompletely controlled inflammation with fibrosis and scarring and these things. So, it's a constantly evolving treatment, goals are, I think, a constantly evolving thing for both patients and clinicians. And I think that it's an important thing to think about for every appointment, and also for both sides of the lane, or for both lanes, and also to recognize that might change going forward, as far as, when we think we've achieved a goal, reassess and say, okay, now is there another step that we need to take? So that's kind of how I approach it.
Okay.
Mm-hmm.
So we have a few questions. One I have is, I always think about when I meet a new patient, one of the challenges is trying to assess their risk tolerance, how worried they are about risks versus benefits. And it changes over time, but it's interesting. I have a nephew who's a financial advisor, and he gives new clients a questionnaire that supposedly assesses their risk tolerance financially very quickly. I would love to have something that's assess someone's healthcare risk tolerance. How do you feel about, do you feel like your risk tolerance changes over time, Sandra?
In my personal experience, yes. And it's funny you bring that up, actually, is I did a series of focus groups a little while ago. And at the end of the focus group, I used kind of a table from a discrete choice experiment. Mm-hmm. So kind of that idea of like weighing in what's more important and providing that information for people to kind of look at, okay, am I focusing on the risks, the side effects, like what's more important than when I'm looking at those treatment options. And I had a great feedback from the patients that were like, what? I wish we had this in the office. Like, this is because every time we make a treatment decision, we should be looking at this, because it might change from one appointment to the next, where maybe today I'm looking at the risks and I want to know the different risks from each medication, but maybe the next appointment or the next time I'm going in to have a treatment discussion, if I'm having to switch over to a new medication, I might be focusing on a different area, and that thing I was focusing on before might not be as important. So for me, I just feel like I have a pretty good understanding of the risks. I feel like overall, the safety, I'm comfortable with the safety of all and I'm focusing on biologics because that's my primary medication I take now. That really helps to maintain remission. And to be really honest, the risks and the nastiness of the disease is greater than the risks of the biologics themselves. The risks of the disease, I think, needs to be discussed as well. It can be really traumatic and really horrible. It's a horrible disease. And I think sometimes, I know, even just in my own circle of family, friends, people I talk to, I just don't think people really have an understanding of inflammatory bowel disease. Often people think it's just like a little stomach thing. If you eat well, you'll be fine, and not have an understanding of the damage it can cause to the body. And that's a really important conversation.
Yeah, it's interesting because usually people come in when they're very sick, at least to Michigan, and they're really focused on the benefits. What's going to get me better? What's going to get me better quickly? And if we do succeed in getting somebody better, a lot of times then the shift comes to the risk. Okay, I'm on this medicine. I feel better. Do I have to stay on it for life? And then that, is a challenging discussion. But then depending on their situation, if their financial situation changes or they lose insurance, then it's a lot of times a financial piece comes to the fore. And unfortunately, sometimes that's when you get into, well, prednisone is 2 cents a pill and it works. So, and it gets the balance between benefits, risks, and costs shifts a lot. And unfortunately, the priorities shift a lot because people's financial situations change. It gets really hard.
Yeah, that is really difficult. I feel very fortunate. I live in Canada. We have a different system and setup. We do, cost can still be a concern to people, but it's not the same as in the US. And it stresses me out hearing other patients talk about it, hearing the doctors talk about it, because I think, oh my gosh, how do they handle, dealing with the insurance companies and managing the costs? And so, it's that. I would imagine it would be one of the top priorities for U.S. patients, is that how much is this going to cost? How am I going to pay for this? And then it seems crazy to me that you have to pick, can I afford this, or do I just let my health go to crap?
Yeah.
Right. So, yeah.
Unfortunately, there's a fair amount of that going on in the U.S. Okay. On the plus side, we do have potentially new meds coming and clinical trials that seem to be working for patients in the last panel. So I'm going to move towards wrapping up. For the folks who are still with us, thank you for hanging in. This is where we begin to close. The main thing I want to emphasize is thank you for coming out. Everyone is going to get a follow-up survey by email. And please fill that out and give us input on what worked, what didn't work. This is our first year virtual, so we could really benefit for some feedback. And let us know what topics could be helpful for future years.